Te hei Māori ora no rongo ki te whai au ki te marama ki a rātou mā haere atura, ki rangi nui I rongo ki papatūnuku. Takato nei, tēnā rā koroa, nō reira ki a tātou tipna Matua, rātou ki a rātou haere atura. No kotorana a hau, ko Clan Fraser aku iwi, ki te taha o tōko papa ko te Clan Warren, ki te taha tipina wahine, ko te Clan Glencoe MacDonald. Inoa nei, I noho ana a hau kei wangi nui o te waka o maungi te teiti, o maunga takitino, tēnā rā koutou katoa. Hi, I'm Fraser Todd, and recently got told I'd talk with my feet. And so if you see my feet over there, and I'm kind of like this, it's because I'm trapped behind here. I'm going to say a number of things that cover the same kind of area as Steve did, and I'm going to go really quickly over those. Because when I was sort of asked to do this talk 6 months ago, I kind of thought I should go over the evidence for prevention, treatment, early intervention treatment, and this little thought in the back of my head, and no, it wasn't cannabis, was kind of telling me, no, you've got these doubts, and you're a clinician first and foremost, and so maybe you need to be letting people know about your doubts. So I'm going to go over that stuff quickly initially, and then I'm going to share with you some of the thoughts as a clinician that have been going through my mind for the past few years, doubts about what I'm doing in this area. You'll know most of them, but I think it's worth raising it in this forum. So, this is what I think I should say, not what I'm going to say. I'm going to start off as a clinician raising a case scenario, and it's very similar to the ones that Jane McMeekin mentioned earlier, because I work in the service that treats the youth drug court people, works with them clinically, but this young person isn't in the youth drug court. It's details are changed, obviously, but it's representative of someone I saw the last few weeks, and it's at the severe end, but it makes the point. So we've got Tama, 16-year-old. He presented under pressure from his whānau due to heavy cannabis use, but he'd recently threatened to kill himself at home. And had some auditory hallucinations on one occasion from an uncle who had passed away, telling him to do so. But the main concern was his cannabis use and the violence that the family feared. He'd had some recent losses. His father had been incarcerated. Uncle passed away 12 months ago. He'd recently had convictions for burglary, theft of a motor vehicle and assault. This is on the back of 15 to 20 previous convictions. Numerous past convictions since the age of 13. Using, I think, actually this is probably the heaviest I've seen in a teenager, and clinically I work with teenagers, so, but 2 ounces a week for the last 4 years, and that's pretty heavy, but yeah. First use at age 9, regular daily use from 10 years old, had moderate to severe dependence, family and uncle's strong gang connections, and they were daily users of cannabis. His father was a drug dealer. There was a violent relationship between his parents, and they separated when he was 6, but he lived with his father from 13 to 14. Didn't go to school since the age of 10. Spent most of his time actually going around with his father, helping recover drug debts. And because of his age, I think that's the main reason why his father got him to carry the weapon, which he also carried at other times to intimidate people. So as we go through and think about prevention, think about how this might have impacted on Tama, the prevention strategies, the early intervention strategies. Because I could be wrong, but I get the sense that prevention works best for those people in the middle, those who might use, but doesn't work that well for people who are going to use heavily or problematically. And that's where most of the problems lie. So, prevention. As Steve mentioned a number of the prevention strategies. Generally, I mean, school-based intervention can be helpful, but overall, I think, especially for those who are going to get those hard, heavy daily use, the hard problems, the dependence, I think it's of limited effectiveness. What is effective is, not relying on school teachers, multimodal, involving families, doing booster sessions and so on, but overall, the effect is probably small. And think about Tama, because he wasn't going to school from the age of 10. His family background was gang-related, daily cannabis use. Is he really going to believe what other people are telling him when his experience since he was born was that heavy cannabis use is normal? Clinical treatments. Again, Steve talked about some of the treatments, and the one multidimensional family therapy, which seems to have the best evidence for it, but the evidence is countenanced by a number of other things. but quite frankly is just way too intensive or expensive for us to ever look at bringing it in our current health system. And then the sort of treatment time we get would depend on where he is in the country as well. We've got a real inconsistency of services, but overall clinical treatment, it works for, a third of people, maybe a half of people. What about the other half? And we've also got policy issues. There's other approaches to prevention worth looking at. There's prevention of high-risk children who it may not be around substance use, it may be more around offending, and there's some good results coming out of early intervention, prevention strategies for high-risk offending kids, which look at social skills, emotions, regulation skills, academic skills, as well as drug skills. In fact, some of the good evidence coming out around cannabis use suggests that you don't actually need to address cannabis use. You can address substance use in general and you'll get reductions in cannabis use. We've also got a number of programs happening in New Zealand. For example, what looks to be a really good program, the Incredible Years program, which is being researched and looks to have some real positives to it. But it's still in the research phase. It's being rolled out for a small number of people. Drivers of crime, which again looks at some of these earlier indicators and what you can do for a small number of people. But the problem we've got is a piecemeal approach. So some of these things that look like they're potentially useful are being done for a small number of people. There's no real link between the different agencies that are supposed to be trying to do these things. So the effectiveness for the population is, for example, is limited. So, too far. Steve mentioned reasons for using. I'm not going to go into that. But to look at, again, some of the predictors and some of the early personal predictors of use, well, I'm not going to go into that. I'm not sure that occasional use is harmful to the point we should be spending a lot of money dealing with it. But heavy use, daily use. We look at the predictors there. Early age of onset, it's been discussed. Alcohol, nicotine use, impulsivity. Externalising problems. So it's behavioural difficulties from a young age. Family problems, family substance use disorder, peer influence, socioeconomic disadvantage, and so on. So there's some clear predictors of heavy use. Not everyone who uses daily is dependent. In fact, maybe 30 to 50% of people who use daily go on to dependence. And the predictors of going to dependence, i.e. having psychosocial problems, if you like, are different. So dependence is predicted by quantity and frequency of use, using to cope with stress, negative life events, the symptom of discontrol, which makes sense, avoidant coping, social anxiety and depression. Social anxiety for getting dependent, depression for maintaining dependence. So interestingly, we've got externalising symptoms, if you like, that are quite significant to daily use, but it's internalising symptoms that predict that going on to dependence and problematic use. And when we look at coping, cannabis does appear to be used to cope significantly, and it does a couple of interesting things. So one of the things that evidence is emerging about is that cannabis actually helps, because of its effect on memory, reduce the negative bias and a negative emotional processing that you get with depression, right? So it can help cope with depression. You don't get so many negative thoughts. It may reduce intrusive memories and post-traumatic stress disorder and therefore ameliorate the symptoms of PTSD to some extent. And it can certainly reduce the anxiety around social anxiety disorder, maybe partly because it is reducing some of those negative biases that you get when faced with social situations. So if you look at prevention for Tama, there's a school-based education wasn't going to work for him. He wasn't at school. The legal status of cannabis wasn't going to work for him. I don't think it made any difference at all, and he's brought up in a gang culture and they have their own rules and their own disregard for the laws. Clinical interventions, well, maybe, but he first contacted at 16. He's had 4 years of daily cannabis use by the time he's actually contacted services, right? So, he's got some serious harm going on at that point. It's a fairly late intervention, even though he's only 16. There are a number of other things that could have been targeted and tackled. And I'll leave you to just look through those briefly, because we'll come back to those issues. If we look at early intervention and treatment, then we know that, as Steve mentioned, most people don't get treatment. There's often poor retention. Interestingly, there's only a couple of studies, because we don't have a lot of good research, that indicates that treating cannabis dependence successfully actually may not improve quality of life. So that raises the question of what actually are we doing? And most people with cannabis dependence, and especially most teenagers with cannabis dependence, have coexisting mental health problems that aren't substance use related. So are we just targeting cannabis? In many cases we're not. And especially in those cases where people haven't responded to that initial treatment, we're probably not just treating cannabis dependence, we're treating a whole range of other problems equally impactful. Steve again has mentioned the treatments. I'm just going to go really quickly through those because I want to get on to, well, first of all to say that the approach to dealing with complex problems in New Zealand, Te Aere o Te Oranga, looks at fairly comprehensive treatment, the importance of being well-being focused, of engaging, of motivation, and going beyond motivational interviewing in terms of how do you motivate people to change. Again, if you want to look that up, Te Aere is available on the web. The key to it, underpinning it all, is the idea of being person-centred, well-being orientated, integrating care for the needs of the person, not the system, and actually ways of putting these things into practice. And so person-centred means with TAMA, you're not going to go cannabis dependence is what we're going to do, we're going to go TAMA. What are the problems in your life? What's your quality of life like? What do you want for your life? And then tie everything in with that. What are your values? And sometimes 16-year-olds will have different values from adults, but they'll still be able to, with help, articulate where they want to go. Right? Which is, we're motivated by what's most important to us. So you use that for the motivation, you put the treatment in that context. What's well-being for TAMA? How do we achieve well-being? One of those things might be actually helping him reduce his cannabis. It's only one of them. So I'm going to ignore that, but this is kind of what I wanted to say. 10 questions about preventing. These are my thoughts over the past few years from a clinical practice base. First, person-focused care. I think it's really, really important. What's the job? As a clinician, I should start with people, not disorders. And I know we all think this, but a lot of our discourse is about cannabis dependence, not people with cannabis dependence. And we ignore or don't mention the other parts of their lives. And in doing so, many parts of the system forget that it's about people. Right? And so how do we bring that back? And I think there's ways you can do it clinically and you can talk about it, but how you actually get the system, the health system, the whole government system that's involved in social welfare, et cetera, to actually focus on the needs of the people, not on this is what my ministry or this is what my service is interested in, this is what I'm interested in. When we look at things are getting more and more complicated, and complex is a good thing, complicated is a confusing thing. We need to make things complex. The history of healthcare is to get more and more specialised, and that's a great thing. We've got lots of evidence about lots of small, fine things that make a big difference, but we lose sight of the big picture, and the big picture is the person in their whānau. And it's that big picture that integrates information. And it's actually also what I think the taxpayer who pays for most of us is thinking that we're doing. I think the taxpayer is thinking that with their taxes, they're funding health for us to help them have a better life, right? And I'm not sure we're doing that. So that's about wellbeing orientated care. I've just talked about that. There are positive and negative pathways. Evidence-based practice. Look, I believe in evidence-based practice. And look, I think, when I read their research and I've heard them speak over the past 2 days, past day and a half, I'm really impressed by the integrity of the researchers and the quality of the research that's being presented in this area, especially the epidemiological research. The history of cannabis is one of shoddy studies, interpretations not justified by the data, and influenced by people's beliefs on whether it's harmful or not. And for some of the people I've met, those beliefs influenced by their personal experience, right? And we've got some really good quality evidence emerging, but it's not clinical evidence, because we've got problems with clinical evidence, and this is psychiatry's dirty little secret. And we bash on with the evidence that we have, because we don't have a lot of alternatives. But our diagnostic criteria lack validity. What is schizophrenia? Well, it's nothing. It's not a thing. It's a thing we've made up. What is depression? It's a thing we've made up that fits 5 of 9 DSM criteria. How do we decide what criteria they are? Well, they're the criteria that allow you to make a diagnosis of depression. There's a huge publication bias with clinical research. As a clinician working with teenagers, I can look at the evidence behind SSRIs and medication for teenagers with depression. And what I know is that there's a whole lot of studies that haven't been published. They didn't say what people wanted them to say. And I don't know how many. I don't have access to them. And I don't know then what the research means about medication. Do SSRIs actually work? Or am I only reading the studies that people have chosen to publish? I really don't know what it all means now. I don't know what depression is now, because it's a whole lot of different things and it's not what DSM says it is. And I think data trawling is really common. We look at p-values, the probability that something is not due to chance. And if you take a study and you throw in 100 variables and you just, without any hypotheses, and you just look at what comes out with a p-value, then some of those values will be positive, significant by chance. Right? And I think there's a lot of research, or I know there's a lot of research that's done by data trawling. Those findings, if you don't hypothesize this and then look for it, those findings are probably pretty flimsy. They get published because they're positive findings. In the area of addiction and in the area of major depression, we've had two of our leading lights, researchers, huge influential researchers, and they kind of said every time they published, here's my conflict of interest. They didn't tell you all of them. Right? Serious embarrassment to them because they didn't declare significant funding from certain drug companies. Well, what do you make of that? A huge body of research in depression, really good research, and then all of a sudden it's like, the leading light is compromised. He didn't tell us he was actually funded significant amounts of money by a drug company for presentations, for research. Well, what do we make of it? So it's getting really tough to know what to make of our clinical research. And this happened earlier on with the cannabis literature, the weight of evidence. This seeming weight of evidence. We've got all these studies, and so the conclusions are all heading up in the same direction, but you go back, and each conclusion is consistent with previous conclusions, but not with data. We get these myths. In my main area of interest, coexisting problems. We've got this myth that integrated care works really well. We've got this myth that motivational interviewing works really well. It doesn't. The evidence is it doesn't work. It engages people really well. That's significant. That's why we use it. Doesn't change substance use or mental health problems. The myth is that it's evidence-based practice. The myth is integrated care, which does make a slight difference, but it's a slight difference, is evidence-based care. Wow. It's actually a myth. There's an awful lot of studies that say the opposite. So that's a question I've got. What do I make of the research? How do I be evidence-based? Research and treatment priorities. And I think it's, again, going back to the research in this area, it's excellent we've got this research. We really need good research from good researchers with integrity. The research on cannabis and psychosis, cannabis and schizophrenia, they're not the same things. There's far more people with bipolar disorder that have psychosis than people with schizophrenia. It's really important. However, have we got our priorities right? Te oro hininaru. 20.7% of the population have a mental health problem in the last 12 months. This is in 2006. Note, 29.5% for Māori. 0.8% anxiety disorders, 5.7% social phobia, mood disorders 7.9%, bipolar disorder 2.25%. The rating system they use, the City, automated computer-based assessment system, doesn't rate schizophrenia because it doesn't pick it up enough. They have psychotic symptoms, but independent research on schizophrenia estimates the rate of around 0.3%. Right? It's not very common. If cannabis use increases the rate of schizophrenia by 15%, that's not very much in the scheme of things. So I think it's a really important issue because I think schizophrenia is a really damaging condition, and if we can reduce it, that's fine. But as a clinician, I see far more cases of depression, far more cases where people are using cannabis with depression. We may debate the etiology, but there's clearly an interaction in terms of further functioning and outcome. And if we look at rates of mental health problems, this is Agosti's research, the National Comorbidity Survey, it's quite old. But even then, if we're looking at the rates of mental health problems in people with cannabis dependence, Depression's over 30%, social phobia 29%, bipolar disorder over 10%, schizophrenia 2%. Right? So I think schizophrenia is important. I think the research is great. I think we've got some other significant problems as well. And I personally, as a clinician, with what I see, I think they're a higher priority. But I'm not sure, and it's open to debate, so that's a question I've got. Social well-being. How important is social well-being to this whole debate? And it's come up in terms of public health. But what the factors in terms of social well-being, that how does it impact on, say, cannabis use, mental health problems? We know there's good emerging evidence that these big 7 factors predict social well-being: family relationships, financial situation, employment, community, friends, social cohesion, levels of trust in the community, overall community health, personal freedom, and personal values. They're really important in terms of social well-being. How important is it in terms of the people we work with clinically? How important is the stuff with Tama? I think it's probably fairly important. Family relationships, divorce rates, 30%. What's the impact of parental separation on kids? Domestic violence, child abuse, these factors seem to me to be important. Financial factors, if you look at this, and this indicates when you look at the number of people who are have the determinants of poverty below the poverty line, actually we've also got serious discrepancies around poverty. Right? And another factor that you can look in is that the children of people on benefits, approximately 75% of those are below the poverty line. Just an interesting quote. Poverty is not an accident. Like slavery and apartheid, it is a man-made and can be removed by the actions of human beings. So when we're doing our work, what are our priorities? Are we struggling against other things in society which are impeding what we do? Those are things I think I've always. I work with teenagers, Youth unemployment, how important is that? Interestingly, while our unemployment rates for youth aren't the highest in the world, as a percentage of our overall employment rates, they're higher than anyone else's. Again, a discrepancy. We're happy to let our youth be unemployed relative to other countries. Is this stuff important? Well, personal freedom, rule of law, we've discussed law, the presence of violence in our society, corruption, faith. Do you have faith in the police? Effectiveness of government services and so on. Social cohesion, I'm not going to go into that for the sake of time. Individual well-being, the risk and causal factors for many mental health problems are much the same. Why don't we address them more effectively? So, for example, if you look at the risk factors for offending, and this is from both David and Richie's studies, just briefly looking through some of those things, and I'm not going to go into detail, but some of those things there, they crop up elsewhere. This is really complicated, so I'm going to talk about it at length. No, I'm not. But this is Ken Kendler's research about, it's excellent research about the risk factors for alcohol dependence in men, just to pick one. Now, if you look through and you look at some of those factors, again, we're talking about factors that seem similar to offending factors, especially in early childhood. Factors for major depression, this is a better slide because it's more colourful. Again, you probably won't be able to see much of it, but where we get to with this is, when you look at the factors for alcoholism and depression from Ken Kendler's research, we've got a lot of factors cropping up, a lot of common factors. Child physical sexual abuse, child parental loss, neuroticism or negative emotionality, if you like. On the other side, child sexual abuse, parental loss, early onset of anxiety, which is kind of related to negative emotionality or neuroticism. But it's also on the other side, conduct disorder. We've got a lot of really similar factors cropping up. And where there are differences, they are often differences because of the way that thing was looked at, and there's still huge commonalities. The reason for that is that actually all mental health problems, and this is partly why all our DSM diagnoses lack validity, can be broken down into two, basically, externalising and internalising. And the things that predict externalising or behaviour problems from a young age, and they all look pretty similar from a young age: poor attention control, that's the key factor. Followed by impulsivity, poor control of inhibition, negative urgency, like the inability to sit there with a negative feeling till it goes away and the need to act really quickly to get rid of it. High levels of sensation seeking, and from there it leads on to, with different genetic influences as people age and different other factors, then it morphs into ADHD, conduct disorder, substance use. A third of people with bipolar disorder tend to externalise. If we look at internalising disorders, it's negative emotionality. It's the propensity to get sad or anxious easily in the face of a stress. And some people do it more than others. And that's a major predictor. And that can be looked at in terms of morphing into sadness or fear responses. And we know that there's a number of factors that significantly predict those temperamental traits going on to disorder. So rumination, which is the ongoing, sticky, negative thinking. Right? Tick, 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 tick. Something bad's happened, you think about it negatively. It drives anxiety or depression. It seems to be a major factor. Avoidant coping, related to negative urgency. So something happens, your first step is distract or avoid. Right? And we know a lot of substance users are highly avoidant coping. Right? They drink or use to cope because they can't sit there with the feeling and use effective problem-solving strategies. The key thing is that we can do things about much of that. And if these propensities we can do things about, and if education is about preparing people for the life ahead, and we have no idea what that's going to hold, kids going to school, starting school at 5 now, they're going to be leaving school in 2026. What's the world going to be like in 2026? They're going to be parents in 2035. What's the world going to be like? How do we prepare them? Is education, does it need to be about resilience, emotion regulation skills, all these, excuse me, attention control, all these things we can do? Should that be the core function of education in the early years and preschool years? Early interventions and preventions, can we prevent these or intervene with these risk factors? Well, yes, we can. Attention control. There's underpinning externalising problems, attention control difficulties. And there are 2 recent randomised controlled trials worth mentioning, one on young people with conduct disorder, the other with behavioural disturbance as a result of fetal alcohol syndrome, which we struggle to have treatments for. And both of them involve 1 hour a week on a computer for 8 weeks at school, doing attention modification, kind of little games that make you concentrate and train your attention. And both of those studies, significant, around about a 30% reduction in behavioural problems as a result of that. So we're starting to get interventions early for these seeds, these predictors. There's a whole lot of things that we can do with young people to help that have got a good evidence base. So, we do need more research. How long do we have to wait before we start? The 5-year-olds going to school, are they going to be 15 before we actually start acting on our research? So why don't we do it? I don't know. No idea. Some reasons. Look, Jane McMeeker mentioned the Christchurch Youth Drug Court this morning. It's like, it's been going for 10 years. It's got good outcomes. The question was raised, why isn't it studied? Why aren't there outcome evaluations? I can answer that because I was involved right at the start. And with the National Addiction Centre involved, we had a lot of research power we could have brought, but it was, thanks Ross, it was led by Justice, who insisted they were going to do the research, and they actually told us initially that they thought quantitative research was unethical. So, I don't know why. So, we didn't really get any more involved. And then also a lot of politics early on with the police especially. The police were great, but the police officers that were involved in the court thought these young people should be punished. And so they were undermining a lot of it. And part of the problem was when the 1-year evaluation came out and said there's been no reduction in youth offending from the youth drug court, and that was front page news in all the press, and the police were commenting, you've got to hammer these people. The response to that was, well, that's true, but the nature of the offending has gone from violent offending to breach of bail. And that was significant. And they were caught for breach of bail because the police officers go around checking up on them really heavily. So we've had actually good outcomes, but the Justice were confronted with that and they stopped researching. So we've got no evaluation data on the youth drug court. But it looks really effective, and it's in Christchurch, and I think one other city tried to put it into place, but they did it differently and they didn't talk to the people who set up the first one. didn't talk to Judge Walker. And so the problem you have there is that they actually use different services to assess and treat, and it just didn't work. So no one else has got a youth drug court. Oh, go figure. It's odd. And look, it's cheap, because all they funded was like 0.5 FTE in our service and in a couple other services for coordination roles, because it's our core business. You know, we didn't get funding for providing treatment for these young people because it was our core business. The funding was all for coordination. It was about 2 or 3 FTEs across the whole service. So, yeah, cheap. Seems great. Don't know why no one else is doing it. Makes my job as a practitioner a lot easier. Who should lead it? You know, we need to implement these things. We need some changes. Who should lead it? Do you really trust the politicians? You know, it's not about trust, is their job? You know, and a really good example is that we had the Law Commission. Now, so many of us think the Law Commission's report was wonderful, really insightful, talked to all the people, had great responses, goes to Parliament. It's not their job to look after the well-being of society, right? It's their job to do a whole lot of things and get elected. Right? And so none of those, you know, most of the recommendations in the Law Commission, great things, really visionary, got implemented. When things do get implemented, they go to individual ministries who don't seem to talk to each other. Then they implement things. And if I can kind of, a chat I had with a colleague yesterday, and if I can take the liberty of mentioning it, for example, we know that community action stuff, setting up community resources, sports teams, whatever, for young people, attaching those to adults who they respect, can make a significant difference in their lives and in social cohesion and the outcome. And so, for example, because of all this fragmentation, you know, the one in Christchurch that does that, 2 FTE staff members and $10,000 a year, and like, go figure, what can you do with $10,000? Well, actually, you know, I can probably do quite a bit with it, but in terms of trying to get, you know, a city of 400,000 people, $10,000 to get young people, it's nothing. It won't. You know, so someone in the ministry had a good idea and they funded it, but it's not going to touch the sides. So, are we worth what we cost? I often think that. I get paid quite well. That's what most of you do. We pay by taxpayers' dollars, most of us. Are we worth what we cost? Do you think the money the taxpayers pay me and you would be more effectively spent reducing poverty, reducing youth unemployment, increasing welfare benefits so that 75% of kids whose parents are on a welfare benefit aren't under the poverty line? Right? Poverty line, it's an easy kind of thing just to say, but you know, when you look at the determinants of poverty, one of the things that struck me was the young people not having a raincoat. Right? You know, middle of winter, off to school, wet, all day, you know, not having a raincoat. Like, I can't imagine that. You know, or shoes, or whatever, or not enough food. I mean, that's what we're talking about. Building social cohesion and trust in the communities. One of the things that is correlated strongly with a lowering of social well-being in our communities is that we don't trust each other, we don't trust our neighbours, there's not trust in society. Reforming education, look, the things I've talked about in terms of what could stop Tama or could reduce, well, he's a hard-end case, but could stop people like Tama coming to see me at 16 with all these problems. You know, do some of these early intervention things work? Yeah, they seem to. Could it have stopped, you know, Tama coming to see me? I think when I see young people and I work with them, it's like, great, I really enjoy it. This is really frustrating, you know, because there's things we know we could have done earlier if we just had the integrity and the guts to do it. It means big change. Should we reform the education system to actually prepare kids for the future? I don't know the answers to most of those. There's lots of things, but how do you do it? So those are my 10 questions, and as a clinician, that's what I kind of think when I'm treating, in the back of my mind, when I'm treating people with cannabis dependence. Don't know the answers. All I know is that actually, I suspect I'm not worth what they pay me. I suspect if they took what they pay me and my colleagues and put it into poverty, we would have far fewer problems than if they gave it to me to treat people at 16.